plays a very important role, like it is a controls the mechanism of all other endocrine glands and regulate their functions and may try to maintain the homeostasis or proper functioning of our all body systems. That is a major function of pituitary gland. So whenever we start endocrine system, first gland which we are going to learn is usually pituitary gland, which we are used to learn. So today we'll talk about pituitary gland, what are the different parts, structure, and how they are their effect. उसके बारे में बहुत सारा last chapter में बात कर चुके हैं, but here we'll talk in more detail. Okay, so whenever we are talking about the pituitary gland, we will not discuss pituitary gland alone because it has a close association with the hypothalamus, and with the help of the hypothalamus and pituitary together, they control the rest of the body endocrine functions. So that's why we always hypothalamus pituitary usually discuss together. Now first we see the pituitary gland's functional anatomy. It is made up of three lobes. One is anterior lobe, posterior lobe, and intermediate lobe. So anterior lobe, this is the anterior lobe, and it is almost from the 80% of total pituitary mass, and it contains three portions: pars tubularis, that is tuberculous, then pars distalis, and uh, pars intermedialis. This is pars intermedialis. So pars distalis, pars tubularis, and pars intermedialis. So there are different portions. Anatomically, we can differentiate them, and this total portion is called infundibulum. Oh, sorry, adenohypophysis, and it connected to the hypothalamus through the stalk, that is called hypophyseal stalk or infundibulum. Then, if you come to the posterior lobe neurohypophysis, it forms pars posterior portion. Pars posterior portion, then infundibular stem, and median eminences. So these are the portion. So median eminences. These are the portion which formed by the posterior lobe, and it has a more neural structure. That's why name is given neurohypophysis. While intermediate lobe is also called as pars intermedia, and it is rudimentary. And in lower animal, it is usually synthesized melanocyte stimulating hormone. Okay. Here we will not discuss about all those things, but here we will discuss about more about the anterior pituitary hormone and posterior pituitary hormone. Now come to the relationship of the pituitary with the hypothalamus, and that is called hypothalamic-pituitary relationship, and it has related with the through two different way. One is through hypothalamo-hypophyseal tract, and another is um, through the hypophyseal pituitary portal system, hypophyseal portal system. So these are two different ways through which the hypothalamus communicate with the pituitary gland. So this hypothalamo-hypophyseal tract is composed of the large neurosecretory axon which come from the hypothalamus, and these are like a supraoptic nucleus and paraventricular nucleus. And from there it goes directly and enter into the posterior pituitary. These fibers directly come into the posterior pituitary through infundibular stems, and there it forms a dilated terminals at the end. So it's not like this. So the hormones they will come and they keep. Okay, sorry. So this is the axon, and with each level, the beads-like structure they will keep on forming. So they will branch, they will keep on forming. The bead-like structure in between will be there, and these beads will be these beads contain the hormones. That's what is secreted by the supraoptic and paraventricular nucleus. These are called Hayring's bodies. And these Hayring's bodies contain hormones. And whenever the stimulus comes, they will secrete these hormones which are in peptide in nature, vasopressin and oxytocin in posterior pituitary gland. The second relation is hypothalamic-hypophyseal portal system, where this consists of the fibers which coming from the RCH nucleus through the tuberal region, and it extends till the median eminences, where the hypothalamic neurons, whenever they stimulate, they release the hormone. This hormone will release and send to the close to the superior hypophyseal artery, where it divided into small capillaries. And again, this capillary combine and it form a long portal vein. And from long portal vein, it comes to the surrounds the anterior pituitary, where again it forms the capillaries, and then it goes to the efferent vein outside the pituitary. Here, this posterior pituitary will be exposed to the high concentration of the hypothalamic uh, hormones. So whatever hormones will release from this comes here and then goes. And so large concentration will present in the posterior pituitary, anterior pituitary, and that will affect the functions of anterior pituitary hormone. Then come to the role of the hypothalamus in endocrinal system. Hypothalamus releases the various hormones which affect the functioning of both anterior pituitary and posterior pituitary. So first it receives the also inputs from the various parts of the body like reticular activating system, thalamus, neocortex, sensory cortex, then occipital cortex or visual cortex, also from the auditory cortex and limbic system also it receives, and that will affect the functioning of hypothalamus. And depend upon those functions, and also receives the inputs from the various sensory receptors like osmoreceptor, thermoreceptors, glucoreceptors, chemoreceptors, and that will affect the functioning of this hypothalamus. And on that basis, the hypothalamus releases the various hormones. So, what are the hormones released by the hypothalamus that act on anterior pituitary hormone? These are growth hormone releasing hormone. So, these are the hormone which stimulate the release of growth hormone. Apart from that, there is also counter check for that releasing hormone. There is a growth hormone inhibiting hormone that is also called somatostatin. And the same somatostatin is also released in GI tract, but it doesn't come out to blood-brain barrier, so they will remain locally at the GI tract. But this is in the brain, and that act directly on the pituitary and inhibit the release of growth hormone. Then there is a corticotropic releasing hormone, corticotropic releasing hormone that stimulate the release of ACTH, adrenocorticotropic hormone, then thyrotropin releasing hormone that stimulate the release of TSH, and that TSH will still stimulate the release of thyroid hormone. Then gonadotropin releasing hormone that affect on a functioning of FSH and LH, and that also promote the growth release of FSH and LH hormone. Then prolactin releasing hormone, which act directly on the pituitary gland and increase prolactin release hormone, prolactin hormone, or prolactin inhibiting hormone, which will decrease the release of prolactin hormone. So these are counter to each other. So there are, if you see here, there are two inhibiting hormone, that is growth hormone inhibiting hormone and prolactin inhibiting hormone. While there are five stimulating hormone: growth hormone stimulating hormone, thyrotropin releasing hormone, corticotropin releasing hormone, and prolactin releasing hormone. So this is how they try to balance the various hormones released by the pituitary itself. Then come to the role of the hypothalamus in regulation of the posterior pituitary. Actually, posterior pituitary hormone doesn't synthesize its own hormone, but it's synthesized by the hormones from the nuclei of the hypothalamus, which secretes, and this contains the neurosecretory cells, and these are called magnocellular cells. These magnocellular cells will release the hormone and forms the tract, that is hypothalamus-hypophyseal tract, and from the tract it comes and lodges into the posterior pituitary, and it's uh, stored in the Hayring bodies of the posterior pituitary neurons, and where they will remain there, still you will get a stimulation, and when stimulation will come, then it will release from the posterior pituitary. There are two hormones which release, oxytocin and ADH. Then come to the hormones from the anterior pituitary hormones. So anti-pituitary hormone, we can divide it into three groups: growth hormone family, glycoprotein family, and pro-opiomelanocortin uh, peptides. So growth hormone family is structurally they are similar to the growth hormone, and these are growth hormone and prolactin. They're structurally they are have similar type of structure, and that's why they put in the one group. In the glycoprotein family, these are thyroid, TSH hormone, luteinizing hormone, and FSH. They're structurally they are a glycoprotein type of the hormone, while opiomelanocortin hormone, these are contain the melanocortin as their part of their peptides, and their adrenocorticotropic hormone, melanocyte stimulating hormone, and then B lipoprotein and B endorphin. So these sorry, beta lipoprotein and beta endorphin. These are the hormones which released by the anterior pituitary hormones. Out of these, here we will talk about growth hormone, prolactin hormone, TSH, LH, FSH, ACTH. Then first we'll talk about growth hormone. This is one of the important hormone in pituitary, and this hormone which promote the growth. And this hormone is a polypeptide in nature and contain 91 amino acids. And with the species to species, the structure of this hormone will keep on changing. So they have a very high species specificity. ऐसा नहीं हम किसी जानवर का हार्मोन हमारे बॉडी में लगा ले और वो काम करेगा. Like not like insulin. So insulin, we can take animal insulin also. That can also work with our insulin receptor. It is very specific. Then it is synthesized by the acidophilic cells which are present in the pituitary gland. And these are also called as a somatotrope, because somato is a cell structure and trope means promotion. So these are the cells which produce the hormone which promotes the growth of the cells. That's why name is given somatotropes. Now how it's secreted? Growth hormone never secreted in the constant form, it always in the pulses. So for few minutes it will high, then it again come to low, then again after some time, few minutes it will high, it again come to the low structure. And major stimulation of this growth hormone is deep sleep. So in deep sleep, there is a high secretion of the growth hormone. Apart from this, during stress, puberty, starvation, exercise, and hypoglycemia will also stimulate the secretion of the growth hormone. Apart from this, it is also inhibited by the various factors and somatostatin, which is released by the hypothalamus. The somatomedin is another chemical. Then obesity, hypoglycemia, and pregnancy will decrease the concentration of growth hormone. Now, how the growth hormone is regulated in our body? So, bolo Dinesh. So, it's regulated by the various level. One is the hypothalamic levels by releasing GHRH and GHIH. So, GRH will increase the production of the growth hormone. So, these are the hormone which is secreted by the hypothalamus, and it is polypeptide which contain 44 amino acids. As you go the higher level of the hormone, the content of the amino acid or length of the peptide chain will be keep on decreasing, and it act on directly on the acidophilic cells and increase secretion of the growth hormone by those acidophilic cells. And how it act? It act through increasing the activity of guanylate cyclase, and which causes increased release of cyclic GMP in the cells, and that will causes the production of GnRH hormone. What are the different factors which affect directly on the GHRH? Hypoglycemia will directly act on GHRH and increase the release of the GHRH. Then emotions, exercise, stress, deep sleep, then increase in amino acids in the blood, like arginine, can promote the growth hormone, and also presence of the growth hormone releasing peptide that can also act on a GHRH and promote the release of the GHRH. Then another hormone, like growth hormone inhibiting hormone, it is a polypeptide hormone made up of 14 amino acids, and it inhibits the GHRH hormone. And this, the factor which act on this release of the GHRH hormone, which stimulate the release of the GHRH hormone, is hyperglycemia and high free fatty acid in the blood. Then there is a negative feedback mechanism also work in regulation of the growth hormone, and the negative feedback is one is controlled by the somatomedin. It is a somatomedin is the substance which produce when growth hormone act on a target tissue. So when a growth hormone act on target tissue, it produces a substance that is called insulin-like growth factor. Structurally, it is similar to the insulin. That's why name is given insulin-like growth factor, and it is also called as somatostatin and somatomedins. And this somatomedins concentration will increase in blood, and this somatomedin concentration will act on hypothalamus and increase release of growth hormone releasing inhibiting hormone. Okay, so that is one where the hormone substrate feedback mechanism. At the same time, the somatomedin directly inhibit on anterior pituitary and causes decreased release of the growth hormone. So by increasing the concentration of growth hormone releasing growth hormone inhibiting hormone, GHIH it should be growth hormone inhibiting hormone, which inhibit the anterior pituitary and reduce the growth hormone release, and also through the directly on the anterior pituitary act and release the growth hormone. Then this growth hormone itself will inhibit the stimulate the release of the growth hormone inhibiting hormone release, and that growth hormone inhibiting hormone will cause a decrease in the growth hormone. So that is like hormone negative feedback mechanism. And third is growth hormone releasing hormone, which inhibits its own hypothalamus and reduce the decreased production of growth hormone releasing hormone that will lead to decreased production of pituitary. So this is how it is ultra short loop, and this is how it will regulate by various negative feedback loops and try to control the or maintain the concentration of the growth hormone within narrow range. Apart from this, there are other factors which affect on the growth hormones, like thyroxine and cortisol will stimulate the growth hormone. Insulin will also causes decreases the release of the growth hormone directly through by decreasing the gene expression. Then placental growth hormone or placental lactogen will also decrease the growth hormone in the pregnant woman. Then obesity will decrease the growth hormone release by directly stimulating the growth hormone releasing hormone response. It causes resistance of the growth hormone to the GHRH hormone. Then neurotransmitters like dopamine, norepinephrine, acetylcholine, serotonin, all will GABA or histamine, all will increase the growth hormone by directly stimulating the release of growth hormone releasing hormone, or by decreasing the release of somatostatin. Then estrogen will increase growth hormone secretion, and that will causes just explain the more growth hormone in premenopausal woman as compared to men. So estrogen have also direct effect on the growth hormone. Then how this growth hormone at mechanism of action of the growth hormone on the various body. So growth hormone act through the hormone receptors which present on the cell membrane, and the family of this hormone receptor is cytokine family, and these are present in almost each and every um, cell of the growth. And once the growth hormone act on these growth hormone receptors, it will stimulate the formation of insulin-like growth factor that is also called as the somatomedins. Specifically, these on the liver also, and that increased concentration of the somatomedin in the body, and this occur through the tyrosine phosphorylation. So it is a tyrosine kinase enzyme will be activated, and that will causes the production of more of insulin-like growth factor. And these insulin-like growth factor will act on a different bodies, different organs in the or different tissues in the our body, and promote their growth specifically via formation of peptide protein formations. And this is how they will increase the like chondrogenesis or also skeletal growth. Then it causes differentiation of the various cells and also causes multiplication in the various cells and causes increase in the cell growth. Apart from this, it also has a metabolic effect. And this metabolic effect, like it has an effect on protein synthesis, it has an effect on fat, and it has also carbohydrate synthesis. Now, what are the actions this growth hormone does? So first, as name is suggests, we'll talk about the growth promoting actions of the growth hormone. Growth hormone promote the linear growth of the body. Simply, it height बढ़ाती है. And how it increases the linear growth? It stimulates the proliferation of the chondrocytes in the cartilage. So this is your long bone. And if you see this long bone, when you are not before puberty, so this one end of the long bone has a cartilage ring plate that is called epiphysis, and it never fuses this central bone and long head of the bone will never fuse, and there's a cartilage part will be there. So on that cartilage, new cartilage will be light, and the पहले का जो cartilage होता है that get mineralized and converted into bone, and this is how your bone length will be keep on decreasing. So suppose this is your normal bone और एक cartilage है, तो यहाँ पे एक और cartilage ring होगी, your head will move up, and this previous cartilage will be solidified. और जब नया कार्टिलेज बना उसके ऊपर एक कार्टिलेज होगा और जो उसके पहले वाला जो कार्टिलेज बना वो सॉलिडिफाइड होगा. दिस इज हाउ length growth will be keep on occurring, and this is what the growth hormone promote. It promote the formation of more cartilage in the epiphyseal end. So यहाँ पे जो प्लेट है यहाँ पे बहुत और ज्यादा कार्टिलेज फॉर्म होगा. मोर कार्टिलेज will form, more length will be keep on increasing. Apart from this, it stimulates the osteoclastic activity, that is deposition of the bone. So osteoblastic cell will what it will does, it will mineralize the cartilage and convert that cartilage into bone. So that will keep on increasing. Apart from this, it also causes a deposition of the bone along the girth. So it also increases the mass of the bone. So bone mass भी increase होगा, length भी increase होगा, और कंटिन्यू होता रहेगा जब तक puberty attain नहीं होती. जब puberty पे epiphyseal plate fuse नहीं होती. Once epiphyseal plate fuse, there is no cartilage, so there is no proliferation of the cartilage cells, and it will not cause further growth of the bone. Then it has also metabolic effects apart from the growth and all those things. Similar effect, growth hormone also causes the effect on other organs and causes a more multiplication of the cells and promote the growth of the liver, promote the growth of the muscles, and also other soft tissues in the body, and their size will be keep on increasing. Then there is a metabolic action of the growth hormone. Growth hormone has a anabolic effect on the protein metabolism, that is, it increases the protein synthesis. And how it can promote the protein synthesis? By increasing the amino acid uptake by the cell. So amino acid absorption by the cell will increase, causes more protein synthesis in the ribosomes, and also stimulate the RNA and DNA, so that more transcription will occur, more mRNA will form, and that mRNA will causes more and more protein synthesis. And this is how it will create negative or positive nitrogen balance. What is positive nitrogen balance? Protein content or protein input and output will measure in our body through the nitrogen, because protein contain ammonia, that is nitrogen part. So हमने कितना नाइट्रोजन खाया है और कितना अमोनिया बॉडी में से रिलीज हुआ. सो इन दैट सेंस विल कंसिडर नाइट्रोजन बैलेंस. सो जितना नाइट्रोजन हमारे बॉडी में गया है थ्रू फूड, उतने नाइट्रोजन यूरिन में से जाएगा. देन वी कॉल इट एज अ नाइट्रोजन बैलेंस. So it causes a positive nitrogen balance. So there is more nitrogen will remain into the body, and less ammonia will be removed from the body, and so there is a more gain of the body will be there. And it also causes a decreased proteolysis or protein breakdown. So protein utilization for the energy and all those things will be reduced by the growth hormone. Then it also has an effect on fat metabolism, and it promotes the lipolysis of the adipose tissue. So it has a catabolic effect on the adipose tissue, and more free fatty acids will be available in the blood, so that free fatty acid will be utilized for the source of energy. Then it has a effect on the carbohydrate metabolism. It has all effect opposite like that of the insulin. So it's also called antagonistic to the insulin. It causes hyperglycemia. It increases the gluconeogenesis, that is, increase glucose production by the liver cells. So from free fatty acids, the glucose will be converted, and more glucose will be available for the cells. Apart from this, it also decreases the uptake of the glucose by the cells. So cells glucose utilization come karta. So glucose will be remain into the blood, while instead of it promotes the cells to utilize the free fatty acid as a source of the energy. So free fatty acid will be utilized more as a source of energy instead of the glucose. It also inhibits the glycolysis. So glycolysis means splitting of the glucose. So it inhibit the glycolysis. So there is no breakdown of the glucose, and it will not utilize as a source of energy, and it increases the production of glycogen synthesis, and that is because more and more glycogen storage will increase in liver and muscles. Apart from that, it also has effect on mineral metabolism. It promotes the bone mineralization. So there is more and more calcium deposition into the bone, uh, and all these effects will occur through the insulin-like growth factor. It causes positive calcium balance, as say more and more calcium will deposit. Apart from the calcium, phosphorus and magnesium will also keep on deposited in the bone. Apart from that, it also increases the absorption of the calcium through the kidney, phosphate and sodium also, and it also causes a reabsorption or retention of the sodium, potassium and chloride inside the body in the kidney. This is how it will try to maintain the blood volume also and try to increase the calcium or mineralization of the bone. Then growth hormone also act like a prolactin. They both are structurally also similar, and there are like a formation of the development of the breast tissue and formation of the milk and all those things also promoted by the growth hormone. Then come to the prolactin hormone. So prolactin hormone is also released by the anterior pituitary and measures other factors which act on to increase the prolactin releases. Prolactin releasing factor or prolactin releasing hormone, then thyrotropic releasing hormone, and then stress. Substances like a dopamine antagonist or androgen blocker or serotonin antagonist will also stimulate the prolactin release. Then oxytocin act directly on the acidophilic cells and promote the promote the release of the prolactin. And then when there is a damage occur to the pituitary stalk, that will also causes a disturbance in the pituitary portal system, and that can also increase the release of prolactin. Then come to what are the effects of the prolactin hormone will occur. During pregnancy, it promotes the breast growth, not during puberty, but is during pregnancy. It increases the alveolar tissue, and number of the tissue also and size of the cell will also increase, and increased more blood supply to the breast tissues, the mammary cells, and more capillary will form, so that the more blood will release to the mammary cells. Apart from that, it also has a lactogenic effect. It promote the alveolar cells tissues to secrete the milk. So it causes a formation of the milk through the alveolar epithelium cells, and also increase the binding of the receptors to the cell also. And both way, it increases the promotion of the milk formation in the breast tissue. So during pregnancy, it keep on developing the breast tissue, but it doesn't have lactogenic effect during pregnancy. It is because of high concentration of the estrogen and progesterone. Because of this high concentration of the estrogen and progesterone, the breast tissue will not show any lactogenic effect under the influence of the prolactin. So they inhibit the effect of the prolactin on the breast tissue, estrogen progesterone, that will not inhibit the binding of the prolactin receptors to the cell membrane, and that will reduce the formation of milk, or there is no milk formation during the pregnancy. Immediately after birth, there is a placenta has been removed from the body, so there is a not that high concentration of estrogen progesterone will be there, and that inhibitory effect will be removed, and that will start lactogenic effect on the breast tissue. Apart from this, high concentration of the oxytocin will release during labor, and that will also promote the lactogenic effect on the breast tissue. That will causes lactogen formation in the breast tissue. Apart from this, prolactin also inhibit the release of the gonadotropin releasing hormone on hypothalamus, and as the concentration of gonadotropin release hormone release, that will causes a decrease in concentration of the gonadotropin, that is FSH and LSH, and that both will decrease the menstrual cycle or ovarian cycle in the female, and that will prevent the menstruation in the lactating mother for long time. Then what are the abnormalities occur when the anti-pituitary hormone will be affected? 1 minute, we'll take a 5 minutes break, and then we'll continue. Okay, now we'll start applied aspect of the anti-pituitary hormone. First, when the pituitary function decreases, hypopituitarism. Whenever there is a decrease pituitary function or hypopituitarism will occur, it will cause a deficiency of growth hormone. Gonadotropin releasing also will be decreased, and thyrotropic hormone function also decrease. So all this will have their effect. Growth hormone decrease, so it will cause a decrease in linear growth. So there will be decrease in the height, so it will cause dwarfism, and also other metabolic activity will also be decreased. But at the same time, soft tissue growth might be a little bit normal, so patient will look more chubby. Then if gonadotropin hormone decrease, then it will cause a decrease in both FSH and LSH. That will lead to loss of spermatogenesis, loss of libido. It will cause complete infertility, impotency, and also sometimes development of breast tissue in the male. That is called gynecomastia. In female, since there is no LH-FSH, it will not cause any ovulation, complete stoppage of the menstrual cycle, and that will lead to complete sterility. Apart from this, secondary sexual character will also disappear because there is no sex hormone, no steroid, no estrogen, no progesterone. And if you see this, after 2 weeks to 2 months, we will not see any gonadotropin hormones also in urine also. So urine excretion will also be stopped. Then come to the thyrotropic hormones. These are leads to decrease in thyroid functions, and almost it occur when the complete destruction of the thyroid gland will occur, and that can lead to marked hypothyroidism, and it is because decrease in the thyroid function, and it can produce, if it is early in the age, it can produce cretinism also, and if after the age, it can produce myxedema. Then a deficiency of adrenocorticotropic hormone can produce Addison's disease, and that leads to, as there is a decreased ACTH secretion, which will promote the melanin synthesis in the skin, that will reduce, and that can cause paleness or sometimes white spots on the, also that is vitiligo also can seen on patient. Then they will become very, very sensitive to the stress, so even they will not tolerate normal stress also, and they can show syncopal attack or susceptibility to the stress. Then because of decrease in mineralocorticoid hormone, there is a decrease as it's aldosterone secret, so there is a net loss of the salt. Salt will lose from the body. As the salt lose, water will also lose, and that leads to decrease in blood pressure and decrease in the volume. Though it will not cause hypovolemic shock, but it will decrease in the blood volume. Then water metabolism, like there is a deficiency of ADH along with the aldosterone. Yes, Sakshi?
Sir, could you please go a bit slow?
Okay. So I'll repeat. It has effect on ACTH hormone also, and it will cause a decrease in ACTH hormone. As there is a decrease in ACTH hormone, the ACTH act on adrenal cortex, and it reduces the function of adrenal cortex also. So all three hormones, like glucocorticoid, will there is decrease in the concentration of the glucocorticoid, and because of the decreased concentration of the glucocorticoid in your body, it will produce Addison's disease, which is also called as a ACTH dependent Addison's disease, and it shows all the symptoms of Addison's disease because of glucocorticoid deficiency. Along with that, one feature we usually see in Addison's disease, that is increased pigmentation of the skin. That will not be here. There will be decreased pigmentation of the skin because in normal Addison's disease, where ACTH is high and glucocorticoid is low. But here as it is ACTH dependent Addison's disease, where ACTH is also very low, so that will cause more pale color of the skin. Apart from this, as the glucocorticoid concentration is very low, body's ability to stand with the stress or fight with the stress has been reduced, and so they will become very susceptible or sensitive to the stress. Apart from the mineralocorticoid deficiency usually does not occur, and also aldosterone release also does not occur, and that's why it will not have much effect on a mineralocorticoid or aldosterone. Now come to the water metabolism. ADH hormone is usually secreted by the posterior pituitary hormone, and if it is affected, then it can produce diabetes insipidus. It is not affected, then there is no problem. What is meant by diabetes insipidus? It increases the more and more urine formation, and more water will loss from the body, and at the same time, because water is losing from the body, it will increase the thirst, and so there will be polydipsia. So you will increase more drink more water, and more urine will be formed. But you are very sensitive. That patient of ADH deficiency is very sensitive to to the hypovolemia because of loss of water. Then it also affects the insulin sensitivity, as there is a decrease in growth hormone level in the body, the response to the insulin has been very much sensitized. So even a small increase in the insulin concentration will cause severe hypoglycemia. So it increases the sensitivity to the insulin because insulin's action is almost unopposed. Then hypersecretion of the pituitary gland. Whenever there is increase in hypersecretion of pituitary gland, there are two conditions occur. One is gigantism and another is dwarfism. Acromegaly. So gigantism occur whenever there is a hypersecretion of the growth hormone will occur, and that occur before puberty, before the closure of epiphysis of the long bone. And as you know, if long bone is not closed, it keep on increasing the length of the muscle because of increased chondrocytes activity in the epiphysis. So there will be increase in the length of the bone, and depending upon at what time there is increased secretion of the growth hormone, the person can attain the height as a 7 foot or 8 foot, and that's why it is also called as a giant. Apart from the long bones, it also causes the increased growth of the membranous bones like bones of the hands, bones of the feet, that will also increase, and so there will increase very thick fingers will be there. Apart from that, the skin features will also, facial features also changes. That is a enlargement of the zygomatic bone, enlargement of the eyebrows, thickness of the screen. Then leaf will become more thicker, tongue will become more thicker. That causes macroglossia, and that can also cause difficulty in speaking. So there will slur speech. Then breast tissue will also increase because of similar action like the prolactin, and that can cause gynecomastia in this patient. Then this growth hormone, when it is secreted by acidophilic cells, they can compromise the functions of the uh, basophilic cells that secretes the uh, gonadotrophic hormones like LH and FSH, and because of that, it can lead to impotency or loss of libido. Then, as a growth hormone has a insulin antagonist effect, it keep on increasing the glucose level very high, and that can causes stimulate the more and more insulin secretion, and that can lead to exhaustion of the beta cells and can cause insulin deficiency and leads to diabetes mellitus. So the growth hormone will causes more and more glucose secretion formation, high glucose level, hyperglycemia will be there, and that hyperglycemia will stimulate insulin, that will can cause diabetes mellitus. So these person with the gigantism are more prone for the diabetes. Apart from this, features of the tumor mass can also seen there, and it can cause increased intracranial pressure, and that can cause headache, or it can compress the optic chiasma and can cause various visual field defects, or sometimes also can cause a gigantism, and many times because of increased intracranial tension, it can also cause the paralysis of the various cranial nerves, more specifically cranial nerve 6, that is abducent. It is very sensitive for the increased cranial intracranial tension. So cranial nerve 6, it can get paralyzed, and that can present as a diplopia. So first sign will shows the paralysis of the sixth cranial nerve is diplopia. So these are the various clinical features which can be seen in a gigantism. And what is the cause of this gigantism? It is usually because of tumor of the acidophilic cells which form in the pituitary gland, and that increase the more and more secretion of the growth hormone. So treatment is, if you could able to remove the tumor, that will be the best treatment, and you can remove it and you can cure it. Then second condition is acromegaly. It occur when there is a growth hormone is excess, occur after puberty, when the long bones, epiphysis of the long bone has been closed. After that, when growth hormone secretion occur, then it will not able to increase the length of the uh, person, or height cannot be increased, but it does causes excessive growth of the membranous bone, like which come from the small bones, like finger bones, wrist bones, facial bones, uh, uh, vertebral column bones, and that all will be keep on increasing, and that will show the different features. So it also causes the growth of the skin and all those things, causes thickened skin. So there will be very coarse features, thick lip, increase more thick tongue, that called microglossia. Then this bridge of the nose and all this will get a broad. Eyebrows will become more prominent. Uh, Mandible will become more protruded. That is called prognathism. The lower jaw will move forward, and it will look like more like a monkey face. And many times it associated with the disturbance in uh, TM joint, or malocclusion between the teeth, and that can also causes the, because of overgrowth of the lower jaw, it can also cause the increased gaps between the teeth. So those things also can be seen. Then there is a large hands, large finger or thick fingers will be there, large feet will be there. So all those things you can see, and because of improper growth of the vertebral column, it can cause kyphosis also. Then internal organ can goes excessively growth and can lead to cardiomegaly, hepatomegaly, or splenomegaly, or renomegaly. And there is also increased sympathetic activity can cause hypertension and sweating. And this person is also more prone for the diabetes. So diabetes also can cause in this patient because of hyperglycemia and other space occupying lesions like increased intracranial pressure, blindness, and all those things can also seen in acromegaly cases. Treatment is similar. If you could able to surgically remove, then it is a good part of this patient to treat them. Then come to the dwarfism, which is opposite to the growth hormone. That is also called a pituitary dwarf, and is due to deficiency of the growth hormone in early childhood. What are the features you can see in this patient? Patient's age will be increased, but it will he'll look like a child, normal child. ऐसा नहीं कि वो कम हाइट वाला आदमी लगेगा. Even if at the age of 20 also he'll look like a very small kid of 7 to 10-year old kid. Height will be small, mental activity will be normal, but little bit chubbiness will be there, but features will be very much immature. There will be the normal childish extremities will be there, and sexual maturity will not be there. So sexually also they will not grow, and they will look like a small kid. So in spite of having increase in the height, and mental growth will be almost normal. So these are the features you can see with the pituitary dwarfism, and if you could able to find it early, You can treat him with growth hormone injections and you can cure it. Then apart from the pituitary dwarfism, there are two other cases which has a similar feature like the pituitary dwarfism, but here growth hormone deficiency is not occur, but the condition little bit different. One is African pygmies. These are occur because of there is a absence of the growth hormone receptors, and so though there is a high growth hormone level and sometimes somatostatin level might be somatomedin level might be high, but insulin like growth factor will not occur, and so it will not increase, and so there will be no growth. So it will also look like a pituitary dwarf. Then there is a Laurent dwarfism. Here it is a abnormal growth hormone receptors, and so it causes a growth hormone insensitivity syndrome. अफ्रीकन पिगी में ग्रोथ हार्मोन रिसेप्टर्स ही नहीं है. अब लॉरेन ड्रॉप में ग्रोथ हार्मोन रिसेप्टर्स होते हैं, but they are insensitive to the growth hormone, and so even if they bind with the growth hormone, the insulin like growth factor will not form, and that will not promote the growth of the individual. So that is about the antipituitary. Now we'll talk about the posterior pituitary. Okay, there are few hormones we have not talked. One is TSH. We'll talk this TSH along with the thyroid hormone. ACTH, we'll talk it with the when we're talking about the adrenal cortex. There is a prolactin. Here, if we'll talk it with the pregnancy. FSH and LH we'll talk when we discuss the reproductive system. Okay, so those hormones. Now come to the posterior. Okay, Lokesh. बोलो लोकेश. Now come to the posterior pituitary hormone. And there are two major hormones which we are going to talk in posterior pituitary hormone is antidiuretic hormones and as oxytocin. So first we'll talk about the antidiuretic hormone, also called as ADH or also called as the vasopressin. This is a polypeptide, also called as neurohormone because it's secreted directly from the neurons and released into the blood. So that also called as neurohormones, and it contains only 9 amino acids. It is synthesized by the both paraventricular and supraoptic nucleus, or magnocellular neurons of the paraventricular supraoptic nucleus in the hypothalamus, and then they stored into the herring bodies into the posterior pituitary gland, and it acts through the various receptors. These are called vasopressin receptors. There is a V1A receptor, V1B receptor, and V2 receptor. V1A receptor usually causes vasoconstrictor. V1B receptor usually causes action on anti-pituitary hormone directly, like autocrine effect, and V2 receptor is usually act on kidney and causes antidiuretic effect. First, we'll talk about the various actions of ADH hormones. So first, we'll talk about action in kidney. And this ADH hormone is one of the important hormone to regulate the water content in our body or water balance of our body. And whenever there is increased secretion of the ADH hormone, it will causes decreased excretion of the water. Free water जो होता है वो कम करता है. So basically, it increases the osmolarity of the urine while decreases the osmolarity of the plasma. तो जब भी आपका प्लाज्मा का osmolarity बढ़ेगा, ADH hormone secrete होगा, and that will decrease the osmolarity of the plasma. So ADH hormone is usually occur on distal columnar tubule, and almost all hormones and drugs usually act on distal columnar tubule and collecting duct. So it is also act on distal columnar tubule and collecting duct, and it increases the permeability of the water in the distal tubules or collecting ducts and causes more and more water in the body. Now how it occur? It binds to the V2 receptors and that activate the adenyl cyclase. So second messenger system is here, adenyl cyclase, which activate the protein kinase on the cell, inside the cell, and that protein kinase causes a formation of the water channel. ये किसी ने मुझे फर्स्ट क्लास में पूछा था, the aquaporins. Okay, these are water channels. Channels will form on the aquaporins, which forms on the plasma membrane of the collecting ducts, and those are cells are called principal cells. And through these water channels, the water will easily move from the tubular lumen of the collecting duct into the interstitial. Lumen में से सीधा cells में आना चालू करेगा. From cells, it goes to the interstitial spaces, and this is how it increases the water uh, reabsorption. Free water, there is not, it is nothing with do with the sodium, and by removing the free water from the urine, it will increases the osmolarity of the urine, and by adding the free water into the plasma, it decreases the osmolarity of the plasma. Now come to the vasoconstrictor effect. This antidiuretic hormone act on V1 receptors and will causes vasoconstriction, and that can lead to increase in the blood pressure. But this usually occur during in little bit more concentration, not in a normal dose. So there is need large dose, and this will be effective when there is a severe decrease in blood pressure. Then only this ADH will be increased and try to increase the blood pressure. Then come to its action on anterior through the V1b receptors. These antidiuretic hormone act on the anterior and causes increased ACTH secretion, which is released by the cell called corticotropes. And this ACTH will act on the kidney, suprarenal gland, and increase secretion of the glucocorticoid. This ADH is also act on the liver and causes glycogenolysis by acting on a V1a receptors and increase uh, glucose release into the blood. Then in brain, various portions in the brain, this ADH is also act as a neurotransmitters, and it involved in a memory or regulation of the temperature, then regulation of the blood pressure, also in circadian rhythm and development of the brain through the V1a receptors. So these are the various actions of the ADH hormone. Now we see the applied aspect. So there can be also called as syndrome of inappropriate hypersecretion of the ADH, also called as SIADH syndrome. Syndrome of inappropriate hypersecretion of ADH hormone, SIADH syndrome. Okay, it is causes because of excessive secretion of the ADH, and that maybe because of uh, severe loss or hypovolemia, or sometimes severe pain that can cause hypersecretion of the ADH hormone, or sometimes there is ectopic secretion of the ADH hormone, and it is like any disease present in the brain that can cause or pulmonary carcinoma or bronchogenic carcinoma that can also produce a substance which acts similar like that of the ADH, and that will show the effect of hypersecretion of the ADH. And sometimes due to liver cirrhosis or cardiac failure, uh, half-life of the ADH will increase, and that can also cause excessive ADH secretion. Now we'll see the first mechanism, surgical trace because pain or hypovolemia. Uh, Suppose there is we're considering this continuous decrease in blood concentration in the body, and will maintain the hypovolemic concentration for a long time. That will keep on stimulating the uh, posterior pituitary gland and keep on increasing more and more ADH secretion because of its water retention property and vasopressin property, and that can keep on stimulating, that can make the cells hypertrophied, and that even after the stress is removed, then also it will keep on releasing the high concentration of the ADH hormone in the body. This ectopic source, it is usually malignancy. So whenever there is any tumor occurring into the brain or tumor occurring in the lungs, can causes the release of the polypeptide, which acts similar to that of the ADH, and that can increase the uh, effect of the ADH hormone. Third is when there's a degradation is affected. So like a liver cirrhosis or cardiac failure, when the half-life of the ADH will be increased, and that can cause high concentration of the ADH in the body. Now, what are the clinical features patient comes with? It will causes a more reabsorption of the water because of high concentration of the ADH. There is more and more reabsorption of the water, and that leads to water retention into the body. That will leads to increase in blood volume and increase in extracellular fluid volume. Apart from this, as the water increases, that will causes hypervolume, more volume will be there. Increased volume will causes a stimulation of the aldosterone, and that aldosterone causes a excretion of the urine, sodium, and that is called hypernatriuria. So there is a uh, uh, water retention but sodium loss, and that will lead to decrease osmolarity of the plasma and increase osmolarity of the uh, urine. That is called hyponatremia because of there is a more water retention but more sodium loss, and that will cause hyponatremia. That sodium concentration will be very less inside the body. And since there is hyponatremia inside the extracellular fluid and more water retention, it will cause a decreased osmolarity of the blood, and now blood will start losing water from the blood से water जाके it will go start going into the interstitial spaces. That will cause edema, and so more and more water will start returning into the interstitial spaces, and it will cause swelling of the body. So it will cause edema. Now, to act on this treat this patient, if surgically, if we know the tumor and all those things, if we could able to remove that tumor, it will be very helpful and cure the disease. But if we could not able to find any tumor, or if we could not able to find any cause, then treatment is democycline, democlocycline, which actually block the effect of ADH on the kidney. So it blocks the receptors of the ADH receptor present in the kidney, and that prevent the effect of the ADH on the kidney, and that will reduce all this effect and can reverse the all effect of ADH secretion. Then there is the opposite of the SIADH syndrome. There is a diabetes insipidus. Here, there is a decreased concentration of the ADH or failure of the ADH to secrete, or there is a decreased effect of the ADH on the kidney. So one is a central diabetes insipidus, or also called as neurogenic diabetic insipidus, where the ADH secretion is not happening, or the failure to secrete the ADH. And there is nephrogenic diabetes insipidus, where ADH secretion is normal, but kidneys fail to respond. So first we'll see the neurogenic. It can cause by congenital. So since birth, that neurons has been not developed properly and will not able to secrete the ADH. Sometimes malignancy will compresses the uh, supraventricular nuclei or paraventricular nucleus and damage those nucleus and prevent the formation of the ADH. Or sometimes we surgically remove the pituitary gland because suppose like growth hormone gigantism है, उसके लिए हमने remove किया, and we remove the part of the posterior pituitary also, and that can cause damage to the and decrease the ADH secretion. Then vascular lesion, sometimes infection of the blood vessel can cause infection in the pituitary gland, and that can also affect the ADH secretion. So these are diabetic when the ADH concentration is low. Another condition, ADH concentration is normal, but the kidneys fail to respond to ADH, and it is occur because of mutation of the gene and causes defective vasopressin receptors. V2 receptor is defective, and ADH is not acting on the kidney. So, what are the clinical features occurred in these conditions? As the antidiuretic hormone is not there, then more and more water will be loose in the urine, and now there will be the large amount of the urine will be formed with a very low osmotic pressure, low specific gravity. So, water will be lost from the body, but sodium will not lose. So, there will be low osmolarity water or hypoosmolar urine will be formed, and large amount of the urine will form. So we are keep on losing the water from the body. Now, as the water is loose and osmolarity of the blood will increase, it will stimulate the osmoreceptors in the uh, hypothalamus and stimulate the thirst center, and it will keep on ड्रिंकिंग द वाटर. सो नॉर्मली क्या होता है, हम पानी बहुत ज़्यादा पीता है, उसकी वजह से पानी यूरिन बहुत होता है. बट हेयर अपोजिट, यूरिन बहुत हो रहा है इसलिए हम पानी ज़्यादा पी रहे हैं. दिस टू ऑब्लिगेटरी पॉलीडिस्पेस मीन्स Because of high urine formation, you are drinking more and more water, and this causes obligatory polydyspepsia. So there is polyuria, polydyspepsia, and if somehow you could not able to drink it and all those things, it can lead to dehydration. There will be very prone for the dehydration. You immediately start feeling thirsty, your tongue will become dry, mouth will become dry, and there is sort of fall in the blood pressure, and it will cause unconsciousness, and it is usually a clinical emergency. How we can treat this diabetic insipidus? We can use the hormone therapy. We can use either ADH hormone, or we can use ADH antagonist, that is desmopressin, that will shows the effect and uh, uh, reverse the all effect of the ADH deficiency. If the case is a little bit mild, we don't want to give desmopressin, all those things, we can give the drug which can increase the ADH secretion. That is clopropamide. It is a hypoglycemic agent, like a anti-diabetic drugs, but it also acts on ADH receptors and uh, increase the effect of the ADH on the receptor, increase the secretion of the ADH. And then there is a clofibrin and carbamazepine. It will also reverse the effect of ADH and increase more water reabsorption at the kidney level, and that can reverse the effect of ADH. Then come to the nephrogenic diabetes. Here, the ADH is not acting on the receptor, so there is no point of giving ADH because it is already present, but it is not effective. So here, what we are giving, we are giving the hydrochlorothiazide. The hydrochlorothiazide, what it does, it it is a diuretic drugs, and now as here, what pathology occurring? Understand the mechanism of hydrochlorothiazide. So this is renal tubule, यहाँ पे H2O है और sodium है. Now sodium is absorbing normally, but ADH is not there, so H2O will be remain inside the lumen. Now what happens because of this? Urine is low osmolar urine will form, and yeah, a very low tonicity of the urine will be formed, and there will be hyperosmolar plasma will be there. Now, what this hypochlorothiazide will, it inhibit the sodium reabsorption, and now its sodium concentration will also increase, and this sodium concentration will increase the osmolarity of the urine. As the osmolarity of the urine will increase, that high sodium will be reabsorbed in the uh, posterior convoluted duct along with the water. So water will also reabsorb, and that will be reabsorbed. That will maintain the osmolarity of the urine. So your urine will also be normally osmolarity. Your plasma will also have normal osmolarity. Though it will not decrease in the urine formation, volume formation, but that will prevent the dehydration and hyperosmolarity conditions in our body. And this is how we can treat diabetes insipidus. So oxytocin, we'll discuss it during the pregnancy cases. So that's all for the today. Any questions, any doubt?